Hello, and thank you for viewing our presentation on our final project assignment, the evaluation of the Your Health is in Your Hands program. The Your Health is in Your Hands program was created for Columbus Metropolitan Housing Authority in response to increased rates of depression and anxiety diagnoses among younger residents, discovered from medical claims data of those residing in CMHA housing. The program was developed to initially pilot children and families who reside in Post Oak Housing Community, one of the properties owned and managed by CMHA. The goal of evaluation is to make sure this program is effective and sustainable. CMHA should be able to continue and expand this program to other communities within their organization. It is important to evaluate the program at this time before additional implementation so problems or design flaws can be addressed early. Evaluation users consist of anyone evaluating the program, which is currently our team, but eventually CMHA will be conducting routine program evaluation and using children not actively participating in the program as a control group. The three evaluation questions are as follows. Question 1. What elements of the program encourage children and/or parents to regularly submit their documented weekly exercise progress? Question 2. How has the program affected participants' moods? And question 3, what has motivated program participants to change their average weekly exercise duration? The details of the collection plan are as follows. The average amount of exercise will be plotted using line graphs based on data from Excel spreadsheets. The program week date will be the x-axis and the average weekly exercise reported using the y-axis. Weekly mood will be tracked on another spreadsheet, and corresponding bar graphs will note mood data on the x-axis and frequency of reported data on the y-axis. To evaluate program participation, the amount of weekly tracking sheets initially distributed will be compared to the amount submitted by families. A graph showing the difference in these numbers will be created. Baseline surveys and comprehensive focus groups will be used to collect participant opinion data and measure overall program effectiveness. CMHA owns and operates over 30,000 housing communities serving 34,000 residents and 14,500 households. Located in Columbus, Ohio, Franklin County, CMHA primarily provides subsidized housing and housing vouchers for low-income individuals and families. In a community partnership with United Healthcare, data was collected on housing community members and priority issues determined to be mental health related, specifically anxiety and depression, and chronic disease. The majority of CMHA's residents are underserved Medicaid population. Two community partners, CMHA and United Healthcare, have been tasked to improve outcomes in these communities. In addition to housing, financial security, and other concerns, this population sees a high rate of mental health issues. This partnership is part of the Aligning Health and Housing Systems, a multi-sector collaboration developed by the Corporation of Supporting Housing, the Council of Large Public Housing Authorities, United Healthcare, and supported by the Robert Wood Johnson Foundation. The program was designed to implement an intervention for Medicaid members ages 5 through 17, and this will provide a different approach to physical activity and mental health at a population level while ultimately reducing healthcare costs through primary prevention methods. The CDC defines mental health as the emotional, psychological, and social well-being of individuals. While these each affect how individuals think, act, and feel, it also helps determine how we relate to one another and how each person handles stress and whether they make healthy choices. Ranging from childhood to adulthood, mental health is considered to be a very important factor at every stage of human life. Children who are mentally healthy tend to possess a positive quality of life and are able to function well at school, home, and within their communities. Children with mental disorders tend to have serious or negative changes in the way they handle emotions, learn, and behave. 3/4 of chronic mental disorders begin by age 24, and half of chronic mental illness starts by age 14. Overall, current data points to 1 out of 5 children developing a debilitating mental disorder. The campaign was based on the idea that exercise is integral for maintenance of mental health as well as decreasing body weight contributing to lowered risk for chronic disease outcomes. Studies show exercise reduces stress and fatigue while improving concentration, alertness, and overall cognitive function. The campaign was developed to target school-aged children to decrease rates of anxiety and depression through physical activity. The intervention will provide pedometers as well as magnetic weekly exercise and mood trackers that can follow the progress of participants. Prior to the program, children and their parents or guardians will be given educational modules and baseline surveys to complete. Exercise guidelines are established and children are told to work with a parent or guardian to develop their weekly goals, how to achieve the set goals, and how to be more observant of their own personal moods. Behavior changes and participation will be incentivized by prizes. We want to make certain that we developed an effective, sustainable program for this community. If there are design flaws, they can be revised now in order to ensure the program's future success. By evaluating the process of the children tracking their daily mood and exercise, we can tell if the children are actively participating, identify their levels of motivation and initiative, and decide if more help or instruction is needed. This supports the program's success by ensuring that the key program intervention is carried out properly. The goal is that by exercising daily, children experience an overall improvement in mood. In most cases, children will need to review their tracking sheets and educational materials with a parent to adequately complete the 3-month program. When developing the intervention, the social ecological model was the primary template for the interpersonal, organizational, community, societal levels within its hierarchy of levels. Studies have determined that the individual interpersonal levels tend to supersede focus when compared to the organizational, community, and policy levels in relation to health promotion efforts. However, the model is most successful when used as a whole. In addition, the trans-theoretical model of health behavior change was used to target self-efficacy and the importance of fluid movement between stages as a realistic representation of human behavior. Bandura's TTM model and the social ecological model both serve to provide insight and a framework to the design, development, and evaluation of the Your Health is in Your Hands program. The overall evaluation framework is a longitudinal-based design aimed to view process implementation and impact of the focus components of the program. The greatest emphasis is to determine that the main objectives, improved mental health status and increased average weekly exercise, are achieved. Question 1 involves process implementation evaluation, where the program activities utilized as intended. Using a longitudinal evaluation design with a comparison group will help determine the effectiveness of resources throughout the life of the program. Question 2 involves impact evaluation. Did the program achieve the ultimate goal of improving mental health status of the desired population? Question 3 also involves impact evaluation. Did the program achieve the ultimate goal of increasing average weekly exercise of the desired population? For all questions, collecting data at baseline and following completion of the program cycle will provide evidence that the main goals of the program are achieved or not achieved based on program design. The evaluation tools are briefly described on this table. The qualitative components within the evaluation framework is the survey data and focus group information collected at the start of the program and end of the program, respectively. The quantitative data is the daily exercise minutes reported weekly, as well as reported associated mood, using the scale of 5, 4, 3, 2, 1, 5 being most happy and 1 being not happy. Now let's take a closer look at our evaluation questions. Question 1 is, what element of the program encouraged children and or parents to regularly submit their documented weekly exercise progress? The evaluation design is longitudinal, including baseline surveys and focus groups, plus a comparison group of children within the community not yet participating in the intervention. The evaluation methods include intensive baseline surveys completed by the child and or their parent guardian at the start of the program, comprehensive focus groups to be conducted at the end of the program, and daily exercise tracking by the child with adult supervision throughout the duration of the program. The data to gather includes a spreadsheet of documented, confirmed submissions of weekly trackers per family, baseline survey data addressing exercise motivation or perceived barriers to commit to daily documentation, and focus group information such as gathering pros and cons about documenting exercise and mood, and overall program feedback. Question 2 is, how has the program affected participants' moods? The evaluation design and evaluation methods are the same as question 1 mentioned previously. The Data to Gather section includes the collection of weekly submitted trackers, spreadsheet of moods tracked, comprehensive graph of average mood numbered 1 through 5 per individual, and relative baseline and focus group data. Question 3 is, what has motivated program participants to change their average weekly exercise duration? Again, the evaluation design and evaluation methods are the same as questions 1 and 2. The Data to Gather includes a collection of weekly submitted trackers, spreadsheets and graphs of exercise duration, both reported before and during program participation, moods tracked, and other relative baseline and focus group data addressing exercise attitudes, habits, time management, exercise barriers, etc. This slide depicts the timeline for the overall evaluation. Please note that weekly counts of exercise sheets and graph creation are implied for each week following the program's start date, but not included in this simple table. Again, there is a baseline survey included in addition to comprehensive focus groups at the end of the program. After the conclusion of the program and focus group, there is a 4-week extensive evaluation when the graphs are created, data summarized, and trends identified. Reports and summaries will be distributed to all evaluation users. Following review, a meeting will be held by these stakeholders to discuss successes, roadblocks, and program improvements. The evaluation team, in collaboration with CMHA, will determine a schedule of ongoing reporting of collected data, noting progress and trends for future modifications and development within other CMHA communities. Data will be summarized using statistics, graphs, and tables, in addition to personalized success stories if recognized and deemed appropriate. Collective findings will be ultimately distributed to the Aligning Health and Housing Systems partners, the Corporation of Supportive Housing, the Council of Large Public Housing Authorities, and United Healthcare, as well as the Robert Wood Johnson Foundation on a regular basis. All content will be made available via electronic means and hard copies. This project has adequate funding due to the collaboration of CMHA, the Corporation of Supported Housing, the Council of Large Public Housing Authorities, United Healthcare, and the Robert Wood Johnson Foundation. According to the program director, Alex Romstead, United Healthcare will be funding the Post-Oak Housing Authority initiative as a pilot program to not only use within their organization, but also similar housing authorities across the nation. Each evaluation task will be done by a CMHA employee with a public health background, average pay $50 per hour with a normal working day of 8 hours. Possible overtime hours and extra budget costs have been allocated in the miscellaneous row, and printing and supplies have also been allocated within the final budget. Some of the weaknesses of the program and evaluation is that the program has not yet been implemented due to the COVID-19 pandemic. Although the original health assessment was done in 2016 and 2017 by UHC and CMHA, interventions to target their community's priority health problems seem stalled due to inadequate staffing, even though data and funding remain available. We hope that our intervention and evaluation plans will be put to good use in the near future. The remaining slides are of our original logic model, identified areas resulting in our evaluation design, questions, and multiple references. Thank you so much for watching.